We will come to prostate cancer part 23. Treatment for non-curable, non-metastatic M0 castration-sensitive prostate cancer. Men with non-curable, non-metastatic castration-sensitive prostate cancer have a rising PSA despite having exhausted all curative treatment options. Men with cancer-related symptoms, men with significant symptoms from locally advanced non-metastatic prostate cancer should probably start on androgen deprivation therapy, castration with or without first-generation anti-androgen therapy. Other intervention may be necessary to relieve the local symptom. Men with no significant cancer-related symptoms, the optimal treatment for this man is unknown. The preferred management options include surveillance or clinical trial. Anti-androgen deprivative therapy is a non-preferred management option. If surveillance is chosen, LDT is standard when metastasis or significant cancer-related symptoms are imminent or present. The optimal time to start the ADT in asymptomatic M0 prostate cancer remain unclear because of the paucity of the data in this man. Dawkins 2016 conducted a randomized trial in men with non-curable relapse after prostatectomy or radiation. Men were randomized to immediate ADT or delay ADT. Delay was more than or equal to 2 years. 5 years overall survival was 5% higher in the immediate ADT groups, 91% versus 86% borderline significance. The immediate ADT group also engaged in less sexual activity and had more ADT-related side effects. Quality of life was similar between the two groups. The Mithal 2018 conducted a retrospective study in men with non-curable relapse after radiation. In men with PSA doubling time 6 months, the risk of dying from prostate cancer was lower when initiating ADT at PSA less than or equal to 12 compared to PSA more than 12. A study by Studders 2008 indicated that untreated men with stage T0, T4, T0, N1, N0, and with PSA more than 50 or PSA doubling time less than or equal to 12 months are more likely to die from prostate cancer. The risk becomes greater starting 1 to 2 years later, with 7 years risk of death from prostate cancer reaching 48% in men with PSA doubling time less than or equal to 12 months and 32% in men with PSA more than 50. The NCCN states that the benefit of early ADT is uncertain in asymptomatic non-curable M0 prostate cancer. The possible 5% overall survival benefit from immediate ADT must be balanced against the high risk of side effect. If watchful wait is elected, then consider starting ADT before the PSA rise above 50 before the PSA doubling time is less than 12 months. Either intermittent or continuous ADT may be used in non-curable, non-metastatic castrate-sensitive prostate cancer. Treatment for metastatic M1 castrate-sensitive prostate cancer. Quantify the metastatic burden as high or low volume patients with symptomatic metastasis, especially bone pain, have a worse overall survival. The median medical or surgical castration is always part of the initial treatment for men with M1 castrate-sensitive prostate cancer. The abbreviation ADT means castration with or without the concomitant use of the first-generation anti-androgen. The recommendation option for treatment of men with castration-sensitive prostate cancer and distal metastasis M1 include ADT, 6 cycles of docetaxel for men men with high volume metastasis, castration and abiraterone castration and evlotamide. This is the recommendation option for treatment of men with castration-sensitive prostate and distant metastasis. We can use ADT and 6 cycle of docetaxel for men with high volume metastasis, or castration and abiraterone, or castration and evlotamide. Castration also and enzalutamide. ADT and prostate radiation, extended beam radiation for men with low volume of metastasis. Other treatment options include ADT alone, which may be administered intermittently or continuously. Reluglox or Reluglox should not be used with abiraterone, enzalutamide, darolutamide, or evlotamide because of potential drug interaction. Remember, Reluglox should be not used with this abiraterone, enzalutamide, and darolutamide and evlotamide because have very serious drug interaction. Reluglox has not been adequately studied when used in combination with chemotherapy, abiraterone, enzalutamide, darolutamide, or evlotamide. ADT and docetaxel in metastatic castration-sensitive prostate cancer with high volume metastasis. ADT and docetaxel significantly improve overall survival and decrease progression compared to ADT alone, but the addition of the docetaxel generates more severe side effects. Adding docetaxel to ADT is not beneficial for men with low volume metastasis. Castration with one of the following medications, abiraterone, evlotamide, enzalutamide in metastatic castration-sensitive prostate cancer. This combination improves overall survival and reduces progression compared to castration alone. ADT and prostate extended beam radiation. This treatment option was studied in STAMIT trial for low volume metastasis. Men with untreated newly diagnosed metastatic prostate cancer were given lifelong androgen deprivation with or without upfront docetaxel chemotherapy and randomized to either no prostate radiation or to a course of prostate radiation. Metastatic burden were classified using Charter trial definition. In men with low volume metastatic burden, prostate radiation improved failure-free rate, survival, and overall survival. In men with high volume metastatic prostate burden, prostatic radiation improved failure-free rate, survival, but not overall survival. Caveat in this study, metastasis detection was based on the conventional imaging, whole body scintigraphy, and CT MRI. So men with low metastatic burden on conventional image should not be denied prostate radiation if more sensitive technique, example PASMA PET scan or PSMA PET, suggests higher metastatic burden. Treatment for non-metastatic M0 castrate-resistant prostate cancer. For castrate-resistant prostate cancer, castration should be continued while other cancer therapy are administered. Retrospective data suggests that continuing castration in CRBC improving overall survival. That's in Tyler mentioned 1993. In men in M0, men with CRBC, no cancer-related symptom, the PSA doubling time less than 10 months, 3 second generation anti-androgen, this evlotamide, darolutamide, and enzalutamide all show improved metastasis-free survival and overall survival compared to placebo. Therefore, any of this medication is recommended for treatment for men with M0 and CRBC. We can use evlotamide, darolutamide, and enzalutamide. In M0, men with CRBC, no cancer-related symptom, and PSA doubling time more than 10 months, no therapy has been shown to improve survival in randomized trial. The recommendation or recommended management of this main is surveillance. Alternatively, options may include any of the therapy listed below. That's the first generation anti-androgen flutamide, biclotamide, or nilotamide. Starting one of these medication will reduce BSA by more than or equal 50% in 30% of the men, and BSA reduction often lasts only few months. Anti-androgen withdrawal men who are already on first generation anti-androgen may have a drop in BSA when the medication is stopped. Change to different first generation anti-androgen BSA who are changed to different first generation anti-androgen. Ketoconazole and steroid BSA decreased by 50 or more than 50% in approximately 50% of the patient and is usually sustained for 3 to 8 months. Estrogen, such diethylstilbestrol using diethylstilbestrol 1 mg per oral cure per day, up to 43% have PSA reduction. Other estrogenic compounds may have similar effect. In M0 with CRBC and cancer-related symptoms, the best treatment is not well defined. One of the medications listed above may be tried. Treatment algorithm for men with CRBC here. This is the first generation prostate cancer. That's the castration-sensitive prostate cancer, metastatic, non-metastatic, and metastatic. This is the castration-resistant prostate cancer, non-metastatic and metastatic. Non-metastatic castration-sensitive, we can curable and treated. Management depends on the cancer risk and comorbidity. Option will include watchful and wait, surveillance, and curative therapy. That's curable and untreated or uncurable. That's the M0, non-metastatic. Not curable, failed local therapy. If asymptomatic, then prefer option surveillance, clinical trial. Other options include castration if symptomatic, consider castration. Castration refers to the surgical castration that bilateral chilectomy or medical luteinizing hormone agonist or gonadotropin hormone antagonist. Relogox should not be used with ebrotron, enzalutamide, darolutamide, or evlutamide because potential drug interaction. Relogox not adequately studied when used combination with chemotherapy, ebrotron, enzalutamide, darolutamide, or evlutamide. Disregard the M0, not curable and failed local therapy. If we have metastatic M1, castration sensitive, germline genetic testing mentioned that low volume metastasis or high volume metastasis. Low volume metastasis, here the best castration and one of the following ebrotron, eblotamide, and enzalutamide. In select cases, castration and prostatic external beam radiation. If high volume, castration and none of the following ebrotron or eblotamide, enzalutamide, and docetaxel. If the resistance non-metastatic, continue castration. If the BSA double in time more than 10 months, surveillance. BSA less than 10 months, eblotamide, enzalutamide, and darolutamide. If metastatic M1 castration resistance, continue castration, germline and somatic genetic testing. Germline, if bone metastasis present, start densomere and zoledronic acids. If the bone metastasis present. No barrier docetaxel, no barrier novel hormones agent, prefer regimen that docetaxel, ebrotron, enzalutamide. In selected cases, we can use radium 223 or sibulacine. No barrier docetaxel, barrier novel hormone agent. Preferring docetaxel, sibulacel, selected case pembrolizumab, and olaparib, and also rucaparib and radium 223. Barrier docetaxel, no barrier, and barrier is the same as barrier novel, with exception for something. Barrier novel also is the same. And this is the end of the session.